Good afternoon, everyone. Today I'm going to present my seminar on the topic neurobiology of OCD moderated by Sir. So first of all, let us know what obsessive compulsive disorder is. It is characterized by a presence of obsessions and or compulsions. So obsessions are intrusive and unwanted repetitive thoughts, urges or impulses that often lead to a marked increase in anxiety or distress. Compulsions are repetitive behaviors or mental acts that are done in response to those obsessions or in a very rigid or rule-bound way, like some stereotypical behavior, some ritualistic behavior. Some patients may have only obsessions or compulsions, but in most cases, both obsessive and compulsive symptoms are present. So the first English term obsessive compulsive was derived from the German, from this German word in the late 19th century, which was translated as obsession or compulsion. For a long time, obsessive compulsive disorder was not independently considered a disorder, mostly either clubbed with anxiety or some other pathology. But Freud gave a description of symptoms, and he gave us spectrum of obsessive compulsive traits, obsessive of the whole obsessive compulsive and its related diseases. He started from some personality, obsessive compulsive personality traits. Then he gave obsessive compulsive neurosis, and then an obsessive compulsive psychosis. What we call today is OCD with inside, OCD with poor insight, or OCD with no insight, and some other pathologies also that he clubbed with obsessive compulsive pathologies. So by middle of 20th century, RCT with clomipramine, they gave they first of all gave us the theory of serotonin hypothesis of OCD. So the pathology was still not very clear, but what their researchers in the mid 20th century could find out was that clomipramine, which was a more of a serotonergic agent, helped in the symptoms of OCD, and it worked better than desipramine, which was a more of a noradrenergic TCA. So they could theorize that serotonin had some role to play in it. So as per ICD-11, it gives a category of obsessive compulsive and related disorders. And under that subheading, there are six further categories. First of all is the obsessive compulsive disorder that we read about in. But other than that, there is also body dysmorphic disorder, olfactory reference disorder, hypochondriasis, hoarding disorder, and body focused repetitive behavior disorder. Olfactory reference disorder is one particular obsession that a foul smell or some kind of smell is coming from particular place or a particular person, and body focused repetitive behavior disorder, for example, see trichotillomania or skin picking behavior. So by as per ICD-11, all of these are clubbed under one category, OC or related disorders. And so it is theorized that the pathology might be the same in all these categories. But, so this first theory that was given for the for OCD pathology was the serotonin hypothesis of OCD. So Zohar and Insel in 1987, for the first time published that two TCAs were given, clomipramine, desipramine, for in patients with diagnosed OCD, and the serotonergic agent clomipramine was much more effective than the noradrenergic agent desipramine. And this is the only evidence till date that uh, this and other the fact that SSRI also works, voxamine also works, the biggest evidence that there might be some involvement of serotonin system. So serotonin is SSRIs and other serotonergic agents are used as a therapeutic agent, but they are not necessarily involved in the pathophysiology of this disorder. So a pharmacological challenge tests have been done to determine the role of serotonin, and MCPP, which is used as a street drug ecstasy, uh, it was found to exacerbate the symptoms of OCD. Similar results were not seen in other anxiogenic agents like lactate, carbon dioxide, yohimbine. Now MCPP, we know it as ecstasy, gives and sometimes gives intense euphoria, but mostly it is a anxiogenic agent. It causes anxiety. It is a serotonin agonist, but acts on mostly on the presynaptic receptors of serotonin. So what this study did was it first of all it gave a metagolin, a non-selective serotonin antagonist to all the patients. Then there were two kinds of groups. Half of them received MCPP and others received a placebo. So the group which received MCPP alone after metagolin, so sorry, two, so the half of the group were received metformin prior to receiving MCPP, other half did not receive metformin prior to MCPP. So The group which received MCBP alone experienced an increase in the anxiety and obsessive compulsive symptoms, but who received the serotonin antagonist prior to receiving MCBP did not see. Since pre-administration of methamphetamine blocked the exacerbation, it is concluded that the exacerbation of OC symptoms was indeed related to the serotonin system. So, further research uh, led to pinpointing of serotonin 1B receptor. So, the role in presynaptic auto, it is a presynaptic autoreceptor which, under normal conditions, reduces the serotonin transmission. So, this theory would explain why a serotonin agonist like MCPP can cause an acute worsening of OC symptoms. A study was so once we knew that if serotonin 1B receptor could be the culprit, so another study was conducted with sumatriptan, which is a known serotonin 1B agonist, and it also caused a worsening of the obsessive compulsive symptoms. So after that, once serotonergic agents were started as a therapy, but still response was there. But even at high doses, sometimes there was delayed response, sometimes minimal response. So research started for dopamine in OCD. So animal models suggested that D1 expressing neurons induced behavior in mice that resembles the symptoms of OCD in humans. Cocaine is a dopamine transporter blocker, and it elevates synaptic dopamine levels, increases the dopamine transporter density, and chronic cocaine use has been associated with stereotype behavior. And people with already diagnosed OCD, when they have a cocaine dependence, it increases the symptoms of OCD. Also, in other basal ganglia disorders, Tourette syndrome, there are also symptoms resembling OCD. So, what clinical trials did was addition of pimozide and haloperidol to SSRIs. It has proven efficacious for refractory OCD, but antipsychotics, mostly second generation antipsychotics on their own, are known to cause worsening of OCD, de novo worsening, sometimes even de novo inducing obsessive symptoms in patients who did not earlier have OC symptoms. So it was seen that the 5-HT2A receptor antagonism of the obsessive compulsive symptoms uh, exacerbates the obsessive compulsive symptoms by increasing firing rate of dopamine neurons. So the serotonin 2A antagonism is mostly once again seen in the second generations, the olanzapine, which is mostly implicated in the inducing the obsessive symptoms. The D2 receptor antagonism is seen mostly to reduce the OC symptoms. That is why mostly first generations have shown some response with the SSRIs. But independently, any antipsychotic given to OCD, still there is no particular research to demonstrate its response. So in 1998, discovery was done of pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. So in patients, based on samples of 50 children suffering from symptoms of OCD and tics. So it appeared to be provoked by a preceding streptococcal infection. So an infection is the beta hemolytic streptococcus induced an autoimmune reaction that generates the obsessive compulsive symptoms. So this study and this discovery of pandas implies that there is some immune component also to OC symptoms. So the symptoms of the pandas patients, they respond directly to antibiotics to remove any remaining streptococcal infection that might be there, and experimental immune therapy such as plasma exchange and intravenous immunoglobulin. So this can further in future lead to research that might even help in reducing the diagnosed OCD that we in adults also by immunoglobulins and other immune therapies. So the studies on pandas have observed that beta lymphocyte antigen D817, which was a vulnerability marker for rheumatic fever, was more common in patients with childhood OCD and than in controls. Even this particular lymphocyte antigen D817 was present in patients with panda syndrome after they are diagnosed after the streptococcus infection, but in other children with OCD uh, and tick disease, it was still shown more prevalence. Another evidence for immunological or infective cause could be that studies of elevated herpes simplex viral antibodies have been found in the CSF of the OCD patients. So this is a table from a meta-analysis, one of the meta-analysis, and the multiple studies that have been done over the years. So it has shown that most of the studies, even though they have shown normal levels of the immune parameters, but some studies have shown positive findings. Like these studies have shown a decrease in the IL-1 beta, the TNF alpha. Multiple studies have shown a decrease in the TNF alpha, CD4 plus. And also we see in this that in this meta-analysis there has not been one study which has shown contradiction. Like for any receptor, if there is decrease, then all the studies have shown a decrease or an increase. Next theory might be leads to the role of glutamate in OCD. Glutamate is the principal excitatory neurotransmitter in adult brain, and striatum is the largest group of receptive neurons in the basal ganglia, receiving projections from the prefrontal cortex. We will later see in the circuitry prefrontal the importance of prefrontal cortex and striatum in OCD. The cell migration within the striatum is controlled by the glutamate and glutaminergic neurons. So the most abundant uh, quantity of the glutaminergic neurons is present in the striatum itself. And striatum is a part of the CSTC circuit, which we will see later. And it is CSTC circuit is involved in the in OCD. So any non-competitive NMDA receptor antagonist like memantine, it acts on the extrasynaptic NMDA receptor. So it may decrease the hyperactivity of the direct pathway of the CSTC and modulate any aberrant connectivity with the, between the other inhibitory pathway. We will see in detail how the pathways work. But memantine added with the conventional SSRI therapy has shown positive results in OCD. So to further demonstrate the role of a structure and the networks in the OCD, functional MRI finding was done, and in these circuits, it was seen in patients with OCD there was increased perfusion and increased metabolism. The activity within the orbitofrontal component predicts before the treatment and after the treatment, there is significant response. So patients, as the symptoms subside and functional MRI repeated are done, it is seen that these correlations that were seen earlier in these particular circuits disappeared after the therapy. Also in OCD patients with hoarders and non-hoarders, there is a significant finding which shows that the hoarders had a lower glucose metabolism in the posterior cingulate gyrus and the cuneus, and non-hoarders had a higher metabolism in the bilaterally in the caudate. So this is a functional MRI of the hoarders versus control. In the hoarders, the lower glucose metabolism was observed in the right posterior cingulate gyrus, and the higher glucose metabolism was observed in the left and right dorsolateral prefrontal cortices. This is the basis of the RTMS therapy given in the DLPFC region. Structural changes are also seen in OCD with a smaller hippocampal volumes and larger pallidum volumes versus controls, but any significant changes in caudate and putamen could not be observed. It is also associated with decreased cortical thickness. So RTMS is being used in the in OCD. In low frequency RTMS, particularly targeting the supplementary motor area and betofrontal cortex, seems to be the most promising approach. So the further, even though the pathology was still only evidence-based and mostly therapeutic-based, but the finding that RTMS given in the DLPFC in targeting these circuits is also giving a positive response further proves this theory of the neurocircuitry. So based on the functional MRIs, based on the other investigations, we found out the CSTC circuit, the corticostriato-thalamocortical circuit. So first of all, this is the sensory motor CSTC circuit. So supplementary motor cortex, it controls our movements, this how we conduct a particular movement. The putamen is seen associated with the learning and sometimes also seen with the addiction, the repetitive behavior. And thalamus is the control room that brings that controls how the transmission, how the sensation has come, and how it transmits it further to the cortex to conduct a particular behavior. So with RTMS and TDCS, we target this particular structure when we give the RTMS in the SMA, the supplementary motor area. The due to abnormalities in this sensory motor CSTC circuit, we see behavior similar to addiction sometimes in OCD. The ritualistic behavior, the going back to the same compulsion again and again. So the next two circuits are the most important in the direct excitatory CSTC loop and the indirect inhibitory loop. Orbitofrontal cortex is a part of the direct excitatory corticostriatal thalamic cortical loop. So in this, we see the orbitofrontal cortex, which is mostly related to the sensory integration, the learning. The abnormality is seen in the circuit which leads from orbitofrontal cortex to the striatum, to the and to the thalamus. The thalamus, as we have just read, is mostly the control room. It is decides from where the sensation is coming and how the motor activity is to be done. So this direct excitatory pathway is what it tells us how to do a particular activity after we receive a stimulus. So we receive a particular stimulus, something has happened, how to respond to that stimulus. So under normal circumstances, this direct excitatory pathway is is like an accelerator, and it is controlled by this brake, the indirect inhibitory CSTC loop. So under in this, the dorsolateral prefrontal cortex, which has our working memory, the attention, the planning. It is once again then the circuit leads to striatum and then the thalamus, the control room. So what it tells, this circuit tells the striatum is the decision making of how, of whether this decision is how to go about this particular procedure, how this decision is, and this circuit, the inhibitory effect of this circuit leads to the uh, stopping of the activity of the excitatory loop, the particular task when we are doing. So where to stop the task, why to stop the task, and when to stop the task. This is the break of this whole process. So what happens in OCD is that there is overexcitation as well as less of braking. So both the circuits, the excitatory direct pathway and the indirect inhibitory pathway, there is a change in the balance. The excitatory pathway is more stimulated, inhibitory pathway is less stimulated, inhibition is less, and this leads to the overexcitation of the excitatory pathway and repetitively this same act. Normal individual, normally functioning CST circuit leads to an either an increase or decrease inhibition of the thalamus in a balanced manner. The thalamus, the control room, is either inhibited or stimulated in a balanced manner of exactly how much to do a task. In OCD, this is out of proportion. So clomipramine. So based on all these theories, we have found out different treatment modalities for OCD. So clomipramine was the first registered agent for the treatment of OCD, which is a relatively serotonergic tricyclic antidepressant. We have just read in a head-to-head comparison of clomipramine versus SSRIs, there is equal efficacy, but as we know, SSRIs are much more safer than the TCAs. So these days, SSRIs are used for the treatment. There is some indication with uh, agents like aripiprazole, but it is mostly either for refractory OCD or as an augmentation therapy, but primarily treatment SSRIs main. Uh, Higher dosages, we need to use higher dosages in, it is seen escitalopram up to 30 milligrams, fluoxetine up to 80 milligrams, sertraline 200 milligrams. That is when patients start responding. And there is also a significant time before we see an improvement in symptoms, sometimes 12 weeks. And as per the guidelines, we have to wait for 12 weeks before deciding either to switch an agent or to augment with another psychotropic. The references, the theoretical parts are mostly from the CTP and OTP, and the circuitry is seen from the latest researches. The images that we saw was Handbook of Clinical Neurology. Thank you.
What is open for questions? Any clarifications, any doubts? Yeah.
The direct excitatory CSTC loop involves the orbitofrontal cortex, the striatum, and the thalamus. So orbitofrontal cortex is mostly involved in uh, the orbitofrontal cortex, the learning that the motor movements that we do on how to go about a particular movement. This excitatory loop tells us how to go about a movement, go about a particular act after we receive a stimulus. The thalamus tells us how to controls this whole act, how to go to a particular act after a particular sensory stimulus is received. The inhibitory CSTC loop is acts in the opposite function. Based on the earlier, the it involves a DLPFC, which has the working memory, the planning, the attention. So based on the working memory and other aspects, it is acts as an inhibitory loop to stop this that particular act. So a change in the balance and overexcitation and less inhibition leads to repetitively the same tasks.
One is an accelerator, one is a brake.
Accelerator and brake.
So accelerator, car is running faster than usual and brake is off, or some would land up in accessibility. That is what direct impact is. You are stimulating OFC, you are inhibiting activity. Synapses, transsynaptically, you are inhibiting or activating. So, excitation. Any other questions? Yes.
So MPC, what MPCC study is not a conclusive study to prove but any particular serotonin role, but it is just a study to study was done after clomipiramine's introduction as a drug to just find out if the serotonin system was involved at some level. So the serotonin 1B receptor, which has a role as a presynaptic autoreceptor, and under normal condition, the role of the 5-HT1B receptor is to reduce the serotonin transmission presynaptic. It is present presynaptically. So theoretically, what the scientists at that time thought was any presynaptic receptor agonist like MCPP would worsen the OC symptoms. This treat name is ecstasy. So what they did was they had two groups. For one group they gave metrogolin, which is a non-selective serotonin antagonist, and to other group they did not give any antagonist. They gave a placebo. Everyone then they gave this agent that they suspected to be it was a known OC agent, but just to prove that serotonin was the culprit. So the people who received only MCPP without any serotonin antagonist, they had a worsening of OC symptoms, and the ones who did receive methagoline earlier did not have any worsening of the OC symptoms.
So overall, they try to deplete serotonin in the brain by MPCC and CBP, and these are animal studies. The whole drawback of these animal studies is that the phenomena of obsessions will never be able to chart. Our animal will tell you that I am obsessed. So by these repetitive behaviors, which are indirect markers, they'll actually presume. That is why these are all theories. We still don't know where the problem lies exactly. Multifactorial, multiple networks involvement is there. There's a concept of small world neurons. Anyone contribute? Any idea? So this go to those direct circuits, indirect circuits. So when you talk about this basal ganglia collection of uh, various neurons, comprising this direct circuit, subsequently next slide of indirect circuit. So this basal ganglia, these circuits, this conglomeration of these neurons making these circuitries. So the collection of these neurons are known as small world neurons. Now, why? Because it becomes interesting. We saw a patient. He came at around 30 years of age with OCD and failed responded with 40 milligram, 50 milligram of fluoxetine. And then after around 7 or 8 years after when he had this, he came to us again. He said, sir, I had severe stretching in my hands and legs. I stopped your medication, and now I can barely walk. I'm having bradykinesia. He was having bradykinesia, and then there was a hypertonia of upper limbs. So, and then he went to the neurologist. Needed CT, and in CT he had basal ganglia cancer. So the diagnosis becomes FAST disease. FAR apostrophe FAH apostrophe R, Fahar's disease. And then it was very interesting because when we looked up the literature, there were few case reports which started with OC and subsequently led to then with Parkinson's after a decade. So he fitted into the literature. And initially, he didn't have any complaint of these symptoms, any stretching, paresthesias, which are supposed to be prodrome of Parkinson's. And this is explained by those calcifications in the basal ganglia, because those calcifications were pressing on these direct indirect circuits and bringing out dopamine choline disbalance, resulting in later on Parkinson. But they would have been small, they presented with OCD. So there it establishes the problem lies there, but we still don't know that are these the only foci of pathologies or other systems or also. But when we published that, Dr. Veena was also an author in that. You can see and Google it. Small world neuron, a rare case of Graves' disease. When Google it, then you will find we had put the images also. So that is why OCD is one of the cases which is more nearer to the neurobiological construct. That is why we always encourage in TMS also other protocols of OCD. So Dr. Nisha is also doing. Any other questions? He was on some symptomatic anti-obsession agent and anti-Parkinson. But obviously prognosis becomes very poor because gangling, the calcification, we can't do much. And then expectedly lost to follow. Must have not done some. We were a little less experienced. We could have offered him RTMS at that point of time, which would have taken care of the Parkinson's symptoms also. We were not giving Parkinson's TMS for Parkinson's at that point. We were very interested and keen on writing it up and subsequently being done. You have seen RTMS returns? No. Good. Any questions, comments? I don't know. No questions, comments. Raviji? Use of height. The use of artificial intelligence is like if you put like this, fantastic. Picture like the use of more aggressive process like deep brain stimulation, so like the facing of the they have significant elite in the concentration. And deep dreams, huh?
Before these legal hurdles, earlier psychosurgery was also one of the treatments done for
Name one psychosurgery.
single acting.
So lobotomy, capsulotomy, then they came to fiber tracks, which were more feasible. Then there came a movie in West which squashed neurosurgery. Psychosurgery was killed by that. Subsequently, it was not taken up. You know? No. You know the movie? Name? Tell me, Cuckoo's Nest. Yes.
The one that flew over to
Yes. So that actually showed it in a very, very bad precedence, and then for decades together it was off. Yes. Dr. Ayushi? Okay. Dr. Asta? Funding is in yes, it's a pity. Anything else?
Theoretically, there is no reason to prefer one particular accessory. Voxamine is seen to cause thus the relief faster than the others. Over a long period of time, 12 weeks trial still needs to be given.
No, right. Basically, only it's a trend and it's a fashion. All SSRIs have same efficacy over time. Only thing is escitalopram. Because there is a study that escitalopram doesn't work in adults and subsequent. Than that, then you have to also follow the minimum age criteria of this anti-obsessional agents. Fluoxamine in context of psychosis, OCD. They have said that it's some definitional response. Otherwise, for exam purpose, never say a name of a SRI. Similarly, never say a name of a second generation antipsychotic or a first generation. What do you like to do? I like to do trifluoperacin. Then you are in soup. I would like to name the first generation or an SSI. Let them come up with any specific one you want to take. Then you have to choose. You get drug interactions. I like to choose escitalopram. Frequent poor compliance. I like to choose fluoxetine. Weight is an issue, so I would like to choose fluoxetine. Constipation is an issue. I would like to choose certainly. Diarrhea is an issue. I would like to choose paroxetine. So again, then you can take advantage of the various exercises. But never say a drug when you're in. Citalopram, not sure because we don't use it here. Escitalopram has not got a good yet. मिनिमम एज 8 साल है, किसी का 11 साल है, 6 है, सबकी में कितना है? 10 or 11. And very good reference is your CPG, OCD, written by Dr. Vaisiri. Very good reference. All of these details are given. You'll go read up. Your comments? Maybe like what Dr. Sarthak did, an outline, then subsequently after every section a summary and more pictures. So it becomes more catchy for the audience, their interns, so it becomes more easy for them to grab everything. So important data like 12 weeks it can come in a box separately, and it can be put it in a cloud kind of a thing where your brain registers it much better. So those kind of things you can build upon. ठीक है क्या?
N-acetylcysteine as an the glutamate hypothesis is there, so as a supplementation due to its effects on the glutamate receptor, but only as a augmentation therapy.
So I think SSRIs, and if no response, then you can go to SGS second generation antipsychotic. And then parallelly, you can go for CBT or clomipramine. Clomipramine becomes second line if in case there is no response. And these are all third line agents: lamotrigine, topiramate, N-acetylcysteine, memantine. So all these becomes third line. But they are individual biases. It's an individual bias. You can always go for higher dosages. Someone coming with COPD, with a lot of weakness. So other systems are helping you out. Some kidney issues, NSL system. But isolated use, you need more evidence. We'll do a small presentation. I just had made it like augmentation strategies in those. When you take it. Thank you.